Hello, good afternoon, everybody. Welcome to the NACA Special Interest Group Population and Public Health P2H webinar. This is the first webinar that we are having. We are launching this on a quarterly basis. So welcome to the first one. Today we have a distinguished speaker, Dr. Amir Sapkota. He's a professor and chair of the Department of Epidemiology and Biostatistics at University of Maryland. He received a bachelor's in science in chemistry and environmental sciences from Clark University in Massachusetts, and then he earned his PhD in environmental health sciences from Johns Hopkins Bloomberg School of Public Health in Baltimore, Maryland in 2005. I knew Amir there, where I was also a student as a colleague, and also I knew him professionally and admired his work tremendously since then. He then went and did his postdoctoral training in environmental epidemiology from the International Agency for Research on Cancer, IARC, a very well-known place for science for cancer research in Lyon, France, from 2005 to 2007. Then he came back to Maryland and joined the University of Maryland School of Public Health in 2007. Dr. Sapkota's background is in exposure assessment and environmental epidemiology. Along the line of his work in environmental health, he has also developed his research in unmasking disparities in climate change driven health burdens, understanding compound hazards, and developing early warning systems to minimize morbidity and mortality resulting from extreme events with seasonal to subseasonal lead time. More recently, he and his colleagues formed an international consortium called Award APR to develop an early warning system for diarrheal disease in the Asia Pacific regions, increase community resilience against threats. He was also a Fulbright Senior Research Scholar to Nepal, where he spent time in 2017. He has over 100 peer-reviewed publications, is very well funded, has a R01, NIH R01, looking at climate change and kidney disease, a NSF grant looking at extreme events of climate change, and he's a co-PI of R21 looking at wildfires and extreme heats. He has been continuously funded through NIH and other grants to work on environmental and climate change topics. So with that, I welcome you, Dr. Sapkota, to our first webinar. Thank you for doing this, and out to you.
All right. Thank you, Dr. Shrestha, for the invitation. So the title of my presentation is Climate Change Infectious Disease, Chartering a Path Forward. I understand there's a lot of people from different backgrounds, so I'm not going to get into the nitty-gritty of the data, but sort of like present the field from 30,000 feet, so we can sort of like get a broader perspective on it. I will do so using two of the projects that have had pleasure of leading in the past. The first one was called Addressing Extreme Weather-Related Diarrheal Disease in the Asia-Pacific region, the acronym AWARD APR, and Awareness Against Health Threats of Climate Change. That's the current project. Both of these are funded through NSF. And after that, I will provide some concluding thoughts. So before getting into that, I want to just sort of like start with this, notion of extreme weather events and how does that look at, local level. So I want to just give a few examples. So this is a headline from Washington Post. It's talking about this once in a 1,000-year rainfall event that happened around BWI, Ellicott City area of Maryland. So this was in 2014, August 12th of 2014. Fast forward just 2 years. This is again another headline from USA Today. This was dated July 31st, 2016. And again, here it's talking about once in a thousand year rainfall event in the same area of BWI Ellicott City that was ended up being very deadly. Um, Again, 2 years later, this is May up to 2018, and in this case, headline from Fox News that's saying the extreme rainfall event that hit the Ellicott City area was once in a thousand year rainfall. So what does this mean? First of all, what does once in a thousand year rainfall mean? Well, it's not like it does not mean it happens only once in a thousand year. What it means, it's talking about a return period. So in any given year, it has a probability of less than 0.1%, right? So it has any given year, this sort of extreme rainfall, the likelihood of happening is less than 0.1%. So could it happen? Of course, right? So there are people who win lottery, and that has a much, much, much lower probability. But the question becomes like, it's like you win the lottery this year, and your wife wins it the following year, and your son wins it, or son or daughter wins it the following year. And when that sort of things start to happen, then you say like, well, that's really little weird, all right? So that's what we're talking about in this case of extreme weather events, that they are becoming more frequent, and when they do happen, they tend to be more intense and longer lasting. And this is in fact what the climate scientists have been telling us over the past several decades, that these extreme weather events are becoming more frequent and longer lasting and more intense, right? And one thing that's really, really concerning is that IPCC has concluded that even if we were extremely successful in our mitigation effort, in other words, if every country across the world cut down their greenhouse gas emission right now next to zero, even if that were the case, these sort of extreme weather events will continue into the foreseeable future because of the changes that have already taken place, right? So these greenhouse gases have a very long half-life in the atmosphere. So the one that we have already released, their impact will be felt for foreseeable future. And to me, as a public health, somebody who works in the field of public health, this poses a fundamental question. How are we going to adapt to these threats as a society, right? So because climate scientists are telling us, even if we are successful in our mitigation effort, we will continue to see such extreme weather events. So we don't have a choice but to learn to adapt to these threats as a society, because these extreme weather events that are tied to climate change are killing people, making them sick right now. So we must, as a public health community, figure out a way to adapt to these threats. So in terms of how climate change is linked to diarrheal disease, turns out warming temperature promotes bacterial growth. Some of these bacteria that cause diarrheal disease tend to multiply faster under warming temperature. And during extreme weather events, during extreme rainfall, these bacterial pathogens spread in the environment. And this is particularly relevant under resource-limited settings of low and middle-income countries where people lack access to clean drinking water and practice open defecation, right? So what happens is during these extreme precipitation events, the bacteria and viral pathogens that are in the feces that from open defecation get sprayed on the environment and end up in drinking water, unprotected drinking water supplies such as rivers, streams, unprotected wells, And since people don't have access to clean drinking water, they don't have access to municipally treated water, their drinking water gets contaminated with those bacterial and viral pathogens, and that's how they become sick. And we call it the fecal oral route of exposure. Right, and this is particularly, like I said earlier, relevant in low and middle income countries such as India, Nepal, Bangladesh. And this data right here is from WHO. It's a little bit old, but back then, like, this is over 15 years ago, Nepal had, almost 15 million people practicing open defecation, whereas in India, it was over 500 million people at that time were still practicing open defecation. And that number, of course, has gone down, but still it is, significant issue on those settings. We go about, adapting to these threats, right? So, but before getting into this, I just want to give you some, perspective about what the diarrheal disease burden looks like across the globe and how it varies between country and within country, right? So this is a figure taken from the Institute for Health Metric and Evaluation that is at the University of Washington. They provide country level and subnational level data on disability adjusted life years or DALYs. So you're looking at diarrheal disease related DALY across countries, and you can obviously see in this, in Africa and Southeast Asia, higher burden of it, right? So there's considerable variability across country. Although diarrheal disease burden has reduced significantly over the past 40, 50 years, but they're still in this, low and middle income countries, diarrheal disease kills a lot of young children and elderly population. And the burden of diarrheal disease, of course, varies across country, but it also varies within countries. So if you look at India right here, there are places like Kerala where the diarrheal disease burden mirrors closely that of more of a westernized countries. But whereas, in the other neighboring state of Telangana, if you look at it, almost, let me see, 500 times, 500% higher burden of diarrheal disease, right? So then this begs the question as to what is Kerala doing that is so different than Telangana, for example, that is experiencing almost five-fold differences in diarrheal disease burden, right? So from the theoretical perspective, for the sake of argument, we can say that if Kerala can reduce its diarrheal disease burden so low, there is no reason why that cannot be replicated in the neighboring state of Telangana, right? And within the same country. So that, for a public health practitioner like us, that's an opportunity, right? So if we are able to replicate, what Kerala is doing in Telangana, there's a, vast opportunity for, minimizing morbidity and mortality associated with diarrheal disease, right? So those are the sort of thing like we, tend to think about. But coming back to this whole idea of climate change and extreme weather events and diarrheal disease, how do we adapt, right? So we have been promoting this idea of early warning system, right? So early warning system per public health adaptation, right? And there are some early warning systems that are out there right now, but there are what we call this weather-based early warning that tells you how things are going to be basically within the next few days, like tomorrow to like maybe next 10 days. And there's also climate-based projection that tell you how things are going to be decades or 10 years from now, 50 years down the road, right? But for a public health practitioners, neither of these are good estimate because as you know from how things unfolded with the COVID pandemic, it takes time to mobilize resources, right? So that that 10 days outlook, 10-day lead time, 1 week lead time is not long enough to mobilize resources. Whereas the like knowing how things are going to be 50 years down the road doesn't really help you plan for like next year, next month, like. So what we want, what public health health department and public health practitioners want is information about how things are going to be next month, next season, right? So that gives them enough time to prepare, and anticipate those threats and respond to it when the time comes. Right. So neither of these are useful in that regard. This is like the weather-based warnings are too short, it doesn't provide you enough time, and whereas climate-based projections are too far in the distance, right? So we have been sort of like arguing for leveraging this, large scale weather phenomena such as El Nino, La Nina, because they tell you, like, I mean, El Nino, La Nina is determined based on the anomaly in sea surface temperature on this equatorial Pacific region. So the warmer phase, when the temperature is warmer than normal, that's called El Nino, and cooler than normal is La Nina, right? So this is, anomaly on the sea surface temperature, but this has a very, very, very strong implication in terms of how weather, pattern emerges across the globe, right? So depending upon this anomaly in sea surface temperature, you can predict how the monsoon rainfall is going to be in Nepal to, in South Africa to New Zealand and so forth, right? So they're very strong predictor. These are called large scale weather phenomena, but they govern weather regime across the globe. And this is a headline from Washington Post. I mean, NBC News Chicago just a few days ago, saying El Nino, this coming summer is going to be a strong El Nino, and they're already saying, how is that going to impact weather in Illinois? Right. So this sort of like this large scale weather phenomena can be predicted, years ahead of time, like in months, if not year ahead of time. So we are trying to see if we can, take advantage of this type of information to make prediction for diseases, right? And there's another very exciting development in this weather forecasting called subseasonal to seasonal weather forecast, right? So this, like NOAA has this S2S forecast that tells you how weathers are going to be 6 months to 9 months ahead of time. Now, these are not very accurate in terms of like, I mean, like if you want to know how, temperature in Baltimore is going to be in July 21st, it's not going to be very accurate. But if you want to look at it in the context of how is that going to be relative to, like the norm, right? So is it going to be above average, below average? This provides a very useful information in that regard. So I put together this award APR consortia back in 2020 that was funded by the National Science Foundation, along with funding from Swedish government and Taiwan. Our goal in this was to develop early warning system for diarrheal diseases with the subseasonal to seasonal lead time. Right. So, we had a lot of fun working on it. It was very challenging, but these are some of the articles that came out of it. And I just want to show you one quick, result of that work. This was, I don't know if the animation works. This is a little bit dated now. This was like few years, I guess like 2 years old. And we tried to do this prediction for Nepal, Taiwan, and Vietnam. We had a limited diarrheal disease data, but it was sort of like more of a proof of concept. Can we do this prediction good 3 to 6 months ahead of time? Right. And then we did, sort of like look back at it, how accurate our predictions were. And, that was, pretty decent. So this set the stage for this next, grant, which is awareness against health threats of climate change. And in this case, we have 8 different countries, again, including Nepal, Taiwan, Vietnam, but we also have Indonesia, and South Africa in this case. So, basically our objective, in the first objective is to understand the linkage between climatic factors and diarrheal diseases. And the second interesting objective of this work is, can we use over-the-counter medication data as a proxy for health data, right? So one of the challenges that we have encountered is the access to health data is really, really difficult. right? So, in a lot of places, such thing, good health records does not exist. And even if they exist, accessing them, like in the case of India, is extremely, extremely challenging. In case of Nepal, these information are recorded sort of like in a monthly basis. So we were able to get a monthly data. But in epidemiological analysis, what we really need is the daily, if not weekly data, right? So one of the things that we are trying to do in case of South Africa, because they have very good, our collaborator there have a very good over-the-counter medication data, and we're trying to see, let's say, in the absence of health data, can these over-the-counter medication data be used as a proxy, right? So they're looking at a specific diarrheal disease medication and see if that works. Um, and then the third objective is really we are, trying to integrate AI to make this enhance these predictive models, like accuracy of these predictive models for our early warning system. So then in the last round, we were relying primarily on statistical modeling, but in this case, we are trying to, leverage the machine learning based models to make those prediction. And then what we really want to do is then use that information to, develop a mobile app so we can convey that information to the local health department, Ministry of Health, and so forth across these different countries. Um, so we just had our kickoff meeting in Vietnam, actually back in January. We had a lot of fun. All the partners were involved. So we had our partner from Nepal, Dr. Meghnad Dhimal is right there. This is Veena from India. And so, we had a very strong support from the local Vietnamese government, local Vietnamese CDC, like in terms of partnering with us in this work. So we are just coming to the end of year one, and we have like 2 more years left with this. We had to encounter a lot of challenges with this particular work because, our obviously, the whole work is focused on climate change, right? So we had to jump through, so many hoops to get the funding released after we were already recommended for funding. It took almost 10 months to get the fundings released. But luckily, our program officer at NSF were phenomenal, and they made sure that it happened. We were delayed, but we received our funding, so that was really, really wonderful. Um, so, I just want to talk a little bit, the take home points on this, and that is this extreme weather events are becoming more common, more frequent, more intense, and longer lasting, right? And the most important thing is, despite our mitigation effort, they will continue. So we must, as a public health community, learn to adapt with this, right? Because it is killing people right now, it is making people sick right now, right? So this whole idea of how do we adapt to this is this one thing that we are proposing is early warning, right? So this is, I must say, this is one of the tools. Early warning is not the answer to everything. This is one of the tools. And of course, we must have many, many other tools in our toolbox, right? So right now we are working to improve the accuracy of this early warning system, prototype early warning system we have developed. And one thing that I'm really excited about is in this phase is we are going to conduct a prospective evaluation. In other words, we are generating forecasts now for Nepal, Vietnam, India for like this coming summer in June, July, August, right? And then we will let the time pass. And then once we have the data from that time, we will do evaluation. How good were we? Right? Because studies up to this point have basically worked with the data and they make prediction for the uh, set aside like certain fraction, like 15, 20% of the data aside, and then make a prediction for that in the past, right? And see like, okay, how good were we in making those predictions? Well, that's one thing, but predicting, making those predictions for the future is completely different ball game, right? So that's where we are working on. And timely and regular access to health data is critical. These early warnings tend to be a lot more accurate if we have the most recent health data. In other words, if we know how things are now at the present or last month, like our prediction for the next month and the following month tend to be a lot more accurate as opposed to if we were working with data from last year or 5 years ago, right? The timely access to data is very critical. And the other thing is really outreach and engagement, right? We can develop these early warnings all we want, but are we going to have a buy-in from the stakeholders, right? So that is really key, and we are working on that. We don't know how that will unfold, right? So if we have a strong stakeholder buy-in, then yes, of course, it may make sense. But if we don't have the buy-in, then that everything is up in the air, right? Um, and then we really want local ownership of this early warning for long-term viability. We can generate this early warnings right now, but obviously, somebody at the local level need to take ownership of it. Otherwise, it will just go to waste basically. And the final thing is what we are talking about is a paradigm shift, right? So up till now, like in our field, public health is supposed to be proactive, right? But in reality, and like because we are all about prevention, right? But in reality, a lot of what we are doing is reactive. Think about what happened, how COVID unfolded, right? So we are always reacting to these things after the fact. But what we are talking in this particular context is proactive public health, where we anticipate this, where we use this early warning to anticipate disease burden ahead of time, we prepare for it, and we respond to it when the time comes, rather than simply reacting to it after the fact. So this is, it may not sound, that, sophisticated, whatever, but this is truly is a paradigm shift, right? So that's what we're talking about. And to do that, we need to have you know, different set of thinking, like a different set of training, right? So like if we want our folks on the local health department, county health department to be working along that line, we need to focus on the training of student right now who is in tune with that sort of like thinking, rather than always responding, always reacting to these health threats after the fact. All right, so that's going to take a lot of work. And Like I said, I just wanted to use this as an opportunity to have a more open discussion around it. So I will stop sharing my slides right there. And, I deliberately did not, get into very specific around, nitty-gritty around data and so forth, because I recognize that, we have a very diverse community here. But I just wanted to present this as in, sort of like proof of concept and this idea. So I will just end it there and welcome any questions, comments. Thank you.
Thank you, Amir. I think that was every time I hear you listen, every time I'm learning something different, something new. So I'm a big um, advocate of climate change and whatnot, but I just had a thought about what about how to I guess, counter, individuals who may say, specifically with climate, with the temperature rise, because I think there's that, famous graph from Canada they always tend to use. If you look at the mortality, rate or counts or whatever in Canada, it is actually more during the winter season, and there
Mhm.
are lesser people who die during the summer season, and they've done that over years. Over the years they took that data, and so there's that theory saying that we as humans, we adapt more towards hotter temperature than cooler temperature. So maybe the temperature rise is not as bad as we think, because we might be able to adapt. It's not like tomorrow. I mean, there are all these consequences, which is more acute, like, things like you were talking about, flooding and whatnot. But if you look at the breadth over the time period, how would you counter, those individuals, and what would you say?
Well, I think, I mean, you raise a very, important point, right? So there's certainly a lot of skeptics and so forth, but I don't think our job is to counter, every single individual, climate deniers, right? I mean, that's not very productive from my perspective, like, so we need to focus on the ones that are willing to work with you, right? And with regards to your point about colder temperature killing more people, yes, absolutely, cold temperature kills, but so does extreme heat too. All right, so very high temperature kills, very cold temperature kills, and there's somewhere in the middle that we are all happy. And that somewhere in the middle, that happy place depends, changes from point to, one location to another location, right? So that minimum, what you are referring to is the minimum mortality temperature. That will be very different in Montreal, Canada, compared to, if you look at that, to Houston, Texas, right? So people in Houston, Texas know how to live with warmer temperature. So they can adapt to it. They are better suited for adapting to the very hot temperature, right? So the minimum mortality temperature certainly, varies from one location to another location. Um, but also, it is, when it comes to who is dying from this, right? It is people who lack the capacity to adapt, right? So when there's a heat wave, it's not people like, us in this room who die from it, who have access to air conditioned home, right? So the first one to die are people who are living on the street, right? And then the next after that are the people who live in a home without air conditioning, or whose electricity has been turned up because they haven't been able to pay their bills, right? Or they are simply afraid to turn on their window AC because they are afraid, if they do that, then they may not be able to pay the electricity bill next month, right? So there's certainly very, very strong disparity, like across socioeconomic strata. Um, and this is, like, the climate change impacts human health in so many different ways, right? So just, this is, I'm not trying to do a self promotion, but I just wrote an editorial that's coming out in the AJPH. They are running a special edition on climate change and health. And they asked me to write an editorial, and I'm focusing on that, about the things that are less discussed, right? So everybody talks about heat wave, cold wave, and so forth, and like, but there are also, attributes that are less discussed, that issues that are more salient. And the one thing that I'm raising on that editorial is the plights of the migrant workers, such as the Nepalese migrant workers who go work in Gulf countries. And what happens is, when you get exposed to very high temperature and you are dehydrated, you end up having acute kidney injury, right? AKI. And then when you get repeated AKI, like over and over, that turns into chronic kidney disease, and that ultimately progresses into end-stage kidney disease, or ESKD. So we have in places like Nepal where these migrant workers are coming back with kidney failure. And I'm not talking about here kidney people with the kidney failure that are undergoing dialysis, all elderly population, right? Primarily over 60, 65, 70-year old. But I'm talking about, in the case of this, in Nepal, workers that are in the 30s, like mid 30s, late 20s, right? So what do you do? Right? I mean, you are late 20s and your early 30s and your kidneys are gone. right? And you have to rely on dialysis for the rest of your life, right? So that sort of thing. And, so trying to bring awareness to this, right? So yeah, there's lots and lots and lots of issue that we are understanding now, and it's going to be interesting moving forward.
Thank you, Dr. Sapkota. That was very, very fascinating. And I really like the way you framed the equity dimension of climate change and climate extremes towards the end. To me, that brings us to the question of the systems level analysis, especially when you're focusing on early warning system. There are so many parameters and so many attributions, and these models are as good as modelers themselves. And so I am sort of thinking from a perspective of someone in Nepal health section, and trying to figure out how do I actually take some of the takeaways of yours in Nepali context. And then with the limited resources, I cannot even dream to think about climate change because these diarrheal diseases are so prevalent in Nepal. So with or without climate change, of course, is going to sort of aggravate those and perhaps multiply those threats and risk to a new level. But at this point, I am thinking more about how do I manage all of these without modeling, which will require tremendous amount of data, tremendous amount of resources for me. So I'm trying to figure out the leverage point. What would be the minimum and maximum leverage point I could actually do it? So what would be your advice to Nepali colleague? It's like, forget about the climate change. Of course, climate change is important, but for a diarrheal disease prediction or early warning systems, what are some of the minimum the Nepali policymaker could actually take on from your ideas, at least because you have the comparative data from Vietnam and India and other places. And so I was thinking, what would be some of the immediate leverage points you could actually recommend?
So yeah, that's great question, Milan. And at the heart of it, what we are trying to do is, develop climate resilient health system. And I should say that, like my comment was not directed towards individual, but this was, like directed more towards, local health departments, government agencies, NGOs, and so forth, right? So knowing how things are going to be next month and the following month, and how that risk differs from one district to another, one community to another, what that enables, what we hope will, transpire is then, folks like, for example, local health, like that are in charge of the local health department can reallocate resources. So, for example, if, maybe you can, direct your rotavirus vaccination campaign in a certain area, right? You in terms of like resupplying your female community health volunteers with ORT. Right, so ORT packages. What district, what specific community should get prioritized in terms of those ORT allocation, right? So that level of decision making. So the idea is, this is, like I said, not the end of it, not the ultimate answer to all, but what we hope early warning like this enables folks on the ground, decision makers, to make that informed decision, right? So in terms of, allocate, whether that be allocating healthcare workers or allocating resources, like deciding in terms of what specific districts should get priority on the rotavirus vaccination. Maybe perhaps one community, like this one area could be targeted for vaccination early when you have limited, and then the next community could be done a little bit later, because in that area we expect to see the peak diarrheal cases, like maybe like a next month, right? So I'm talking about that level of informed decision making, right? Certainly, you are absolutely true. Diarrheal disease has been around for a really long time, and in fact, diarrheal disease have been going down for the past 40, 50 years, primarily because of improvement in water sanitation and hygiene, more availability of a rotavirus vaccination, and so forth. But what climate change, these extreme weather events, is doing is, in a sense, reversing that progresses, right? So what we are arguing for is using this sort of tool to help community adapt to threats of climate change. And I'm giving this example of diarrheal disease just as as a case study, but that same approach could be applied to dengue fever, like other vector-borne illnesses, Zika virus, and but also other chronic climate sensitive chronic diseases as well. So this is just the principle could be applied to many other diseases. And this is sort of like, a proof of concept. And if it can be done for diarrheal disease, then it can certainly be done for other climate sensitive infectious disease, as well as some chronic outcome as well.
So, can I just
Yes,
quickly make a
please. Yes,
comment? Yeah.
yes, please.
The reason I'm asking this is because my own work in glacier and glacial lake outburst flooding, and one of the key things that came out of all the studies is like, hey, we need an early warning system for glacial lake outburst flooding so that we can save a lot of people. And as good as these early warning systems are, when you bring it to Nepal and have a discussion with the Department of Hydrology and Meteorology, or even the Disaster Risk Management Authority, the first thing they keep telling us, like, they understand the problem. They understand how climate change can reverse some of the gains we have made. And this is nothing particular to your study or anything, Amir, but just to make sense of how some of these key elements of modeling could be sort of applied in Nepal in a way that makes sense to them in terms of their resources. Mm-hmm. And for us, in early warning systems of glacial lake outburst flooding, the main idea was the mismatch priority between the local level and the national level. Mm-hmm. Although the national level would have full investment in taking on climate change mitigation practices because there is money. But mm-hmm. once you bring it down to the local level, the mismatched priorities are in a sense that there are so many other threats that the early warning system for the glacial lake outburst is just one of many. Mm-hmm, and mm-hmm. so this is where a lot of I would say, sort of it gets dissolved into many of these. And so one of the things we try to do was to make it locally relevant, how the local floods and how the precipitation patterns of the local level have changed. That made a lot of sense to the local people. Mm-hmm. And so in my case, the attributing factors for the climate change modeling or the early warning system could be a surveillance of some of this disease, mm-hmm. and that could bring a little more local resources. And so mm-hmm. that would make a lot more sense than trying to tie this up with a much mm-hmm. bigger issue. Yeah. Yeah. And so making it locally relevant is the mm-hmm. same case here in Phoenix. We have an early warning system for heat. And as you know, urban heat island and heat waves kill a lot of people. Mm-hmm. But none of those make sense until you come talk to people about the settlements and unhoused population and exposure factors. And so those are what, and you covered it. I'm sure your work has done a lot of work, but I'm just trying to come up with some of the salient factors for the local level for Nepal. That's all. Yeah. Yeah. Thank you. It was great.
Absolutely. Absolutely. Great point. Thanks, Milan. So I see there's a question from Arthi. How do you ensure that stakeholder relationships, especially with community partners, are not extractive but genuinely reciprocal, given differences in power, resources, knowledge system across contexts? I'm asking this as I'm teaching global research methods course and have been talking about systemic justice. Okay, yeah, I mean that's a great point. That's a great point, Arti, and the way our approach has been to make it, like so engage communities from the onset, but also make sure that everybody benefits from it, right? So the in terms of resource allocation, but also in terms of the credits, authorship, acknowledging everybody's contribution. So even in the kickoff meeting, we try to have stakeholders from each of the location. So we had academic partners and local stakeholder. So we paid for those local stakeholders to come and attend meeting in Vietnam. So um, we try to engage them as much as possible, but there always could be more. We always try to solicit input from our stakeholders, and during this, like we have this regular meetings that are routinely attended by the stakeholders too. So they are aware of what we are doing, what is in the horizon, and so forth. So yeah, I think there's certainly that interesting dynamic, community partners versus researchers and so forth. We are mindful of it, but if you do have a specific suggestion how we may be able to do a better job of addressing those, would love to hear that.
Thank you so much. No, I was just wondering if there were any specific strategies that, sort of have proven to be most effective just to sort of maintain this trust and coordination across
Mhm.
these diverse stakeholders.
Yeah.
Obviously, there are many strategies, right? But I was just interested because it's very diverse in all of these countries
Yeah,
that you're
yeah,
working in.
absolutely. And one thing that we are dealing with is, with regards to the data as well. Certainly our partners in the global south feel, one of their complaint has always been, you guys come and, do these studies, collect this data, and then you go and your student graduates, you publish all those papers, and and then you forget about us, right? So there's certainly very mindful of, we are very mindful of that. So that's why we are trying to engage them. And if there's a follow-up study, resulting from this data, we try to, include the same partners, so they can benefit from the work, right? So certain, but there's it's such, the trust is such a huge issue.
Thank you.
So, Amir, the other thing is, when we look at, climate or weather, I think with the extreme weather, with extreme climate, I think we have been successful in terms of predicting it, I think. But in terms of the non-extreme, that kind of, will impact us down the road, many, many years, our grandkids and their grandkids or whatever. Um, I always get puzzled. We have made so many scientific advancements, but in terms of predicting weather, we are so far behind, even with our all those satellites and and
Mhm, mhm.
and whatnot.
Yeah.
Do you think there is like some major thing that people are not looking at, or are very hesitant to look at, that is actually impacting this, change in climate?
Um, I am not a climate scientist, but my understanding is, the accuracy of those weather prediction drops very rapidly, right? So we are very good at predicting how things are going to be tomorrow, then day after, but after 5, 6 days, the accuracy drops significantly. And it is particularly true if you are talking about month ahead of time, if not decades, right? So the climate models are so decades, 10, several decades to 100 years out. Whereas, like this in between, the sub-seasonal to seasonal lead time is what I talked about. And that's where a lot of interest is right now. And there has been considerable improvement on those subseasonal to seasonal weather prediction, though. Like even compared to just 5, 6 years ago, those predictions are a lot better now. Is it, good enough to tell you whether or not you should take umbrella in August 25th? Absolutely not, right? Right. But in terms of, compared to, your normal, like relative to average, is it going to be higher or is it going to be lower? For that level, I think we are getting much, much better. But like I said, I'm not a climate scientist. I don't know if there's anything they are missing. And if it was, I'm sure, I mean, these are very incredibly smart people. They would have, thought of it. I don't know. So I couldn't answer your question in that regard.
No, I was just wondering because
Sure,
we talk about climate change and health, like human
sure,
health. So
sure.
I'm leaning a little bit, towards the direction of the concept of one health, where I
Uh-huh.
think it's the animals,
Mhm,
it's our planet, it's the agriculture,
mhm.
trend that we have that's all impacting. And I was
Right.
wondering if we are only looking at one
Yeah,
component,
yeah,
but then
yeah.
not looking at the holistic way.
Yeah, absolutely. And that concept of One Health is so important, right? So important. And particularly when it comes to this spillover event, right? I mean, that interface between urban, urban and rural, but also between, humans and animals, that, that's where a lot of those accents are. And there's, I mean, if we I want to keep referring back to the COVID, right? So COVID was, I mean, it's virus, right? Viral infection, but it was very efficient in terms of spreading, right? Like like it spread pretty quickly. But in terms of killing people, it was a lousy killer, right? Even in the very early days, like the case fatality rate was something like 2-3%, right? On the other end of the spectrum, like same like other virus, like if you look at Ebola, it's lousy in terms of spreading from people to people, but it kills almost anywhere from 50 to 90% of the infected people, right? It's the same type of virus, right? But like, I mean, later on, I mean, who's to say that there's not going to be a virus that is as effective as coronavirus in terms of spreading, but as efficient as Ebola in terms of killing its host, right? God forbid when that day comes, right? But we need to be thinking about that. We ought to be investing on that because nobody thought COVID would have happened, and this is, like this is where the One Health would come in, like and how do we plan for that day, right? And if that were, like, I mean, the virus mutates, for example, because of all this new condition or whatever, and if that day comes, then how are we going to respond to that, right? So
Yeah, I mean that's a great thing that you said. It's a lousy virus, but from their perspective, they are smart virus because
yeah,
if they kill us, they are dead too.
yeah,
They're here to
yeah.
stay. So,
Mhm.
and I wonder, if you look at the human side too, one place that the environment, climate change people might want to work with is the flu vaccine people because flu vaccine we predict a year ahead. It's also a hit
Mhm.
and miss, but it does take into account swines and birds and
Mhm.
whatnot. What is the trend there, kind
Yeah.
of thing. So almost looks like they may want to work together. Others, I think there was something I saw on the chat that is from Dinesh. Amir, can you see that?
Open space focusing on migrant workers and interest in our soil
Yeah.
with migrant history were under 40 years of, yeah, some occupational heat stress among the construction workers in Chitwan. Yeah, definitely, Dinesh bhai. Yeah, so I'm following your work. Yeah, certainly very interesting. And this is, what I try to raise on the AJP is editorial, like among some of the things that are not receiving as much attention, right? So the other thing is, I think that is less discussed. I mean, not at all discussed, should I say, is changes in monsoon, right? So like, I mean, a lot of the world, depend on monsoon for agricultural productivity, right? Particularly in the South Asia and so forth. But what is happening with climate change is sort of like disrupting the monsoon pattern from timing of monsoon onset, when the monsoon rainfall comes, the monsoon withdrawal, the duration of monsoon, right? So that is going to have a tremendous implication on agricultural productivity. I should not say that will. It is already having a considerable implication on agricultural productivity, because you cannot plant rice in August in Zappa, right? That there's a very narrow window where you must plant rice, like in terms of the seed germination and, like growth and so forth. So what climate change is doing is like disrupting the timing of monsoon onset, like monsoon arrival, monsoon withdrawal. And so that in turn then results into, loss of productivity, crop failure. Then what happens is that leads to malnutrition, right? And then so many other cascading impact of that, right? So we're not even paying attention, that hasn't been, receiving as much attention. There's certainly like same thing with like the pollen season and so forth, like in the North America. Many of these things, have not received attention. So I think like it's, we need to be, for those of us like who are starting, for, like younger researchers, certainly bringing attention to those, just not focusing on mortality and hospitalization, like all-cause mortality, all-cause hospitalization. There are so many other things we need to be looking at it too.
Amir, just among many new things I learned today, and thank you, it's as illuminating as the last presentation you had, was this kidney disease, the connection between the heat stress and kidney disease. What evidence is there to suggest that this is related to heat stress, not related to other environmental causes or the public health related to, let's say, obesity or some diet related stuff? So I'm just curious, is there any solid evidence or any literature you can lead me to? Because this sounds like a new frontier to me.
Absolutely. So this whole idea of heat exposure and kidney disease came about after observation that were made in the sugarcane workers in South America. Right. So these sugarcane workers, just like in the Gulf country, they go and work out in the sun, like midday sun, like work under very, very extreme heat. They're completely dehydrated. So they were coming down with the initially called chronic kidney disease of unknown etiology, because they didn't know what was contributing to that. Right. So initially, the idea was they were drinking too many sugary drinks, or they were exposed to this wildfire smoke from, burning those sugarcane field and so on and so forth. And there were like other chemical exposure, so forth. But later on, it's, like now it's becoming clearer that heat is playing a very major role on that. And there was one study that was done, I believe, in Nicaragua, where they actually divided, the workers into two groups, right? So one group of worker like was a control group, they didn't receive any intervention, but there was another group of worker that were receive intervention, and the intervention in this case was, ample liquid, during work hours, but they were also provided frequent break under shaded, area, and like adequate rest, right? And then they followed them over time. So and then they were measuring kidney function, like at the beginning and and after the intervention. So the kidney function continue to decline among the workers that did not receive intervention, but the decline stopped like almost completely among the group that received the intervention. In other words, that the workers that were receiving adequate rest and break in a shaded area and enough liquid to drink and all of that stuff, like the kidney function decline stopped basically. So
Wow.
that is, in epidemiology, we call it Hill's criteria of causality. One of the main, criteria for establishing that causality is, does the risk disappear after you remove the exposure? Right. So this was a very simple study, like very done on a very little budget, but it was able to show that, like when they removed that, intense exposure, that decline in kidney function stopped. So like for me, that provides substantial evidence. And then there's, like so many other studies, that have looked into it from a different angle. So yeah, certainly this is very well established on the agricultural worker in South America, but also in India, Sri Lanka, and migrant workers returning in Nepal. So I think it's getting more and more clearer now. 5 years ago, 7 years ago, it was a big question mark. It was still a lot of,
Yeah.
like debate about it. But now the field is coming to agreement that yes, it has something to do with it. There are, of course, other things involved on it
So
too.
tapping on what you and Milan were talking about, has anybody looked at, internal migration, meaning people who are up in the hills, who live in
Mhm.
a cold, cooler temperature,
Mhm.
who migrated to the flatlines, the Tarai, where the
Mhm.
temperature is totally different, probably a difference of 10 degrees or something. Have they even looked at those people and see maybe the kidney disease is, chronic kidney disease is higher among those people?
I'm not aware of it. I'm not aware
I
of
was
it.
just wondering because if
If
it's
you're
the
talking
heat,
in the
yeah,
context of Nepal, but it
yeah.
has to be like really extreme heat, prolonged exposure, right? So I'm talking about, you have like you're working 8 to 10 hours, 12 hours outside, right? So it may not be like, a lot of those folks, moving from the hills to the plain region, like at least in the context of Nepal, everybody does have access to, like homes and shaded areas and so forth, right? So they are not working 12, 14 hours out there on 110, 120-degree temperature, right? So
Yeah.
maybe on the western part, Birendranagar, Madhav, I don't know. I have not never been to Birendranagar and those areas, but
No, I think what you pointed out is more of a, if you're a migrant labor in Gulf countries, you're working not only in extreme heat, the clothes that you may be, and you're not getting break and all that. It's not so much that, yeah, you move from hills to down in the plain and you're going to start having kidney diseases. I think it's the acute and extreme condition.
extreme, yeah. Mhm.
Kidney is basically, well, I mean, physiologically, it's going through such a stress, your body, that is going to produce the effect that it is producing.
Yeah. I think even in Phoenix case, which we where we received like a lot of heat-related mortality, hydration, proper hydration was identified as like a number one. And then, as Amir said, my colleague Jennifer Vanos and City of Phoenix, once they started to have these timed and frequent breaks and a shaded area, creating shaded area, and actually even creating the bus stops that have like a shaded areas from
Mhm.
those, and that seemed to work. But I was never aware of connection between the heat stress and kidney. But this seems like a solid evidence. Great, Amir, learn a lot.
Yes. Okay. In the interest of time, I totally forgot that we're 7 minutes away from what we, because it was too interesting. So
Yeah.
so with that, I'm gonna stop the recording.